How's it going, guys? Pass a little question for pathology for step one. 38-year-old woman, she has a diagnosis of a malignancy and we have a biopsy shown. Okay, and this is showing us a Samoma body. So Samoma body is a ring-like accumulation of calcium, and there's some cancers, you can see them in USMLE. Not excruciatingly high yield, but they're on the real exam. Okay, students have mentioned how they show up. So you can see these in papillary thyroid carcinoma. You can see them in serous cystadenocarcinoma of the ovary, mesothelioma, meningioma. Let's just hop through the answer choices here. Choice A, decreased serum parathyroid hormone. Wrong fucking answer. Okay, doesn't relate whatsoever. Primary hypoparathyroidism. I'd say the two highest yield points you need to know about a decreased parathyroid hormone. Number one, this can occur following thyroidectomy. Okay, so if they give you positive Chvostek sign, twitching of the masseter with palpation, or they give you a carpal spasm, Truccio sign of hypocalcemia, that can occur following removal of the thyroid glands, okay, because you're removing the parathyroids at the same time. So down arrow calcium, down arrow parathyroid hormone. The other important point would be DeGeorge syndrome. Okay, so agenesis of the third and fourth pharyngeal pouches, third pouches being the two inferior parathyroids, the thymus, fourth pouch being the superior parathyroids. So you'd also have a decrease down arrow for parathyroid, down arrow for calcium. Wrong fucking answer. Choice B, elevated serum calcitonin. Wrong fucking answer. So calcitonin would be increased in medullary or medullary thyroid carcinoma, not papillary thyroid carcinoma. Okay, so medullary thyroid cancer, increased serum calcitonin. You can get C-cell hyperplasia. I've seen that in an NBME question. So calcitonin, you need to know, inhibits osteoclast activity. Okay, they really want you to know the mechanism for that. And then exogenously, you have bisphosphonates such as alendronate. They also inhibit osteoclasts. So bisphosphonates exogenously are the equivalent of calcitonin endogenously. And also medullary thyroid carcinoma has amyloid on biopsy, okay, which is apple green birefringence with Congo red stain. And medullary thyroid cancer can also be part of MEN2. Okay, so 2A and 2B. So both MEN2s are going to be RET proto-oncogene, and you're going to have pheochromocytoma medullary thyroid cancer. Then MEN2A, you're going to have parathyroid adenoma or diffuse foregland hyperplasia. 2B, you'll have mucosal neuromas, marfanoid body habitus. Wrong fucking answer. Choice C, mutation, RET proto-oncogene. Wrong fucking answer. So as I just said, RET would be for MEN2, okay, for 2A, 2B. A bonus point I can mention is that when you get the MEN2 syndromes in USMLE, they need not tell you everything in the constellation. Okay, so you're not, a patient in real life isn't going to instantaneously have all of the findings. And on the NBME exam, what they can do is just tell you, patient has medullary thyroid cancer, which gene is mutated? And the answer is RET. And students confused because they're like, oh, I thought RET was like MEN2 syndrome, which you have all these other findings. Like, yeah, but NBME doesn't give a fuck. They'll just give you one finding. Okay? Wrong fucking answer. Choice D, normal serum TSH. Correct answer. So you need to know that in malignancy of the thyroid gland, malignancy being papillary, follicular, medullary, anaplastic, etc. So for cancers of the thyroid that have malignant potential, meaning they could potentially, I should say malignant, which means they have metastatic potential. Patients are going to be euthyroid almost always, sometimes hypothyroid. Point is, they're not going to be hyperthyroid. So nodules that are cold, meaning they're non-secretory, those are way more likely to be malignant. Okay, so if a patient has a nodule and is hyperthyroid, TSH is suppressed, that's a good thing, quote unquote, because it means it's very unlikely to be malignant. So a hot nodule is known as a toxic adenoma. It's a long discussion. We could talk about evaluation of thyroid nodule, more 2CK stuff. I know many of you studying for step one, but just real quick, if you have a thyroid nodule, you're going to measure serum TSH next. If it's normal or elevated, next best step is ultrasound if it's listed. If it's not listed, choose FNA. If TSH is decreased, you're going to do iodine 131 uptake scan as next best step. So real quick, final answer choice, Singer ring cells, wrong fucking answer. So these contain mucin. These are classic for gastric cancer, okay? So a leather bottle appearance of the stomach, linitis plastica. So these can metastasize bilateral to the ovaries, called Krukenberg tumors. So signet ring cells contain mucin. Wrong fucking answer. You know the deal. Make sure to make more content. If you like my stuff, subscribe my channel. Appreciate your time. That's it.